Hello, dear Dental TV community. Today I have a special guest that I know for many years, and it's Waldemar Polido, originally from Brazil. And I have to tell you a story. When we first met, he invited me to the ITI meeting in Gramado in the south of Brazil. And I thought, hey, Brazil, samba, and all these nice things. And I I flew over Sao Paulo to Porto Alegre, and then we drove into the mountains, and I was like, hey, Waldemar, where are you bringing me? This is like in the Black Forest. This is like
Yeah,
Germany or Switzerland.
that's right.
This is not Brazil how we see it. But I realized that Brazil has is a huge country, is a huge country with different cultures, with different populations. So in the south, it's more European. I think the more north you go, it's more African, or I don't know how we can say that. It's a diversity of people living there.
Yeah.
Mm. Now, how many years is it now that you moved from Brazil to the US?
It's a great pleasure to be talking to you again on your dental TV. It's a great channel, great social media communication, very educative. I share with all my residents and even dental students and colleagues, of course, here. So I think we met even before going to Gramado, I think because we met in one of the ITI community meetings many years ago.
Yeah.
In, I want to say Istanbul or even before that.
Yes. Yeah.
Then when I was in Brazil, I was the ITI chair and I organized the meeting where I am from, the south part of Brazil, which is a lot more European style, like you described, very well described. It still is a big tourist part for Brazilians. Because if you live anywhere from the center portion to the northeast and you cannot afford to go to Europe, or even if you can, you just go south and you have that experience. So we organized the ITI Brazil Congress back in the day. So that I think was, I want to say 2015 maybe.
Yeah, 14 or
because
15.
14 or 15. Because in 2016, I started to prepare to move to the US. And then I'm here since March of 2017. So it's been 8 years and a little bit. March, I completed 8 years here.
Where exactly are you? Maybe
I am in Indianapolis. So the city here is called Indianapolis, Indiana State, Midwest. So most people know on the map where Chicago is. So you drive south of Chicago. If you drive 2.5 hours, that's where we are. We live in a small town called Carmel, which is just outside. You'll love it because there's a lot of golf courses here, a lot, and really good golf stuff. And I remember we found you a golf spot in Gramado when you went that year. And in fact, you played with Kia Pasco, another friend from Italy, and he was here visiting us 2 weeks ago.
Oh, cool.
But he had a back problem, so he could not play golf, but he was about to play golf. Anyway, so this is where we are. It's Midwest. It's called the Indiana University School of Dentistry, which had a big name in some 30 years or so ago because big books that we studied as dental students like Schaefer, Hein, Levy, Pathology, McDonald's, Avery, Ray, Pediatric Dentistry, they were all written by those guys when they were professors here. Of course, they're all retired, some passed. So IU here is trying to get back into being a #1 school. It has improved a lot recently. It's not yet at that top-notch level that we would love to be, like Michigan or other newer schools, Harvard, Boston, Tufts. But I think it's a really good school. It's a nice place to live. It's a U.S. Midwest. You have good quality with good price. You can drive to Chicago if you want to spend the weekend. And it's usually a 2.5 to 3 hour flight anywhere in the U.S.
Oh, cool.
And
so what is your position? I remember you were a prosthodontist, and then
no, I'm an oral maxillofacial surgeon.
Are you?
Yeah.
Okay.
I am an oral maxillofacial surgeon.
Oral surgery.
Yeah. So I finished quickly summary of my professional career. I finished dental school in Brazil in 1984. We just celebrated 40 years of dental school graduation. I went straight into a full-time oral surgery residency in Brazil, which was tied to a master's degree. So that took me like 3.5 years. Then I got an opportunity to come to Dallas, Texas, which still is considered one of the best oral surgery residencies in the United States. And back in the day, it was the mecca of orthodontic surgery, which was my passion, still is. So I spent another 3 years in Dallas. Then I came back to Brazil and worked, and then I got involved with implants later after I finished Dallas. And then I was then Brandmark. Usually I had the luck to scrub in surgery with Professor P.I. Brandmark himself, learn from him. And then in 2003, I think, yeah, I had the chance to go to Switzerland for my first time. So I went to Bern with Professor Boozer. And then I started to get really involved with the ITI in a local, national, international level. I was part of the ITI education committee, the global education committee for 8 years. Consecutive years. I participated in several treatment guides, and we wrote the new version of the SHC book. So through that connection, a friend of mine, the prosthodontist, Dean Martin, he was here in IU and he wanted someone with my profile. So I applied, and it was a family decision, also professional decision. So my position here is a full-time clinical professor. I'm a professor level in maxillofacial surgery, where I started doing a little bit with the residents and more with the dental students and implants. But now my time is 80% or more dedicated to the residents. We have a 4-year full-time residency, single degree, we call it in the US, DDS. And I teach a little bit the dental students too, but there's a colleague that runs now the dental students clinic. And my work is mainly anything digitally involved in technology stuff. I love that. And so we do, I'm going to say 40% is about implants, 40% is orthodontic surgery, and 20% is a little bit of everything else, a little dental filler here, and it's a little cyst there. I do not do any cancer, but trauma, I do a trauma. 20% is split between whatever comes through the door.
This leads me to a question. When I was a student, and when we were dental students, implant dentistry was just, okay, it was already there because it started in the 1960s, but it was not really, let's say, popular. How much do dental students learn about implant dentistry today? And how do you see, because I know that there are like 1,500 or more different implant systems around the world. What do you teach dental students? Because this is always a question. I know that any dental schools have affiliations with some companies to get also some support for education and some grant for research. But how do you attack the topic of teaching implant dentistry to dental students?
This is a really good question and a challenging one. Every day we have to deal with that. So our approach here is this. For each dental school in the United States has a little bit of a different approach. There is not a standardized way to do it. Some dental schools do not have residency programs that the dental students get to place. Here at IU, we do have a perio program and we have an oral surgery program. So dental students do not really place any surgically placed implants. They may assist the residents. So the patients are split technically evenly between perio and oral surgery. The dental students clinic, they do have a didactical course on implantology where we basically explain the theory, what is an implant, what is osseointegration, surgical details, not brand related. Restorative aspects. A prosthodontist actually is the one that runs the course, and I am a guest speaker for this course. So I do 3 lectures a year to them, and I run the surgical hands-on. They do have a surgical hands-on in models, the dental students. Now, dental students restore single crowns, posterior single crowns, and they restore overdentures, which in our ITI, I think will be the straightforward concept. So if they have a patient, they refer either to perio or oral surgery. Residents, we plan it together, and then we place the implant, residents, and they restore. They can come to assist. Now, so as far as brand, we have a business agreement with the company. I don't know if you can say names or not, but
you can.
We have names. We know. We have an agreement with Straumann. We are an ITI center. We have a good educational grant where we get some implants at a very low cost related to the dental students. So we charge a lot less when a dental student is restored. But when we lecture, it's not brand related. It's just basic foundation level information. And then when they restore Straumann implants. We had some Nobel as well in the recent past, and I now are actually looking into another brand to cut the costs a little bit and have another brand to give the residents even the opportunity. So that is how it works here. It's an implant didactic course that has a practical component in mannequin surgically, but they do get to restore. And the team is all on board. So we organize together. So there's not a arguments between what prosthetic stitching and what surgery stitching. It's just one big course.
Yeah. So my question is related to this. Why do we have so many different implant brands around the world? We don't have 1,500 composite brands. Why is implant dentistry something special when it comes to how many systems there are on the market? Because the basics, if we're honest, the basics are always the same.
Yeah,
So
I agree.
I always tell people the most important tool when doing implants is having a cone beam CT.
Right.
If you know where the bone is, I always say, look, drilling a hole and placing an implant, if there's enough bone, is, I think,
Not rocket science.
Not rocket science. But again, why do we still? What is your opinion? I'm always asking people with so much experience like you have. Why do you think it came to such a huge number of different implant systems over the years?
I don't really know the answer to that, but that's a really good question. If we will start talking philosophically about it, Brenemark, implants are so old. There are books that show the ancient Egypt, they had implants. If you look big, but they never worked. I remember being in a neurosurgery residency in Brazil, and my professor told me, you will make a lot of money on implants, removing all this crap that is around, subperiosteals and spade and all those things. Then you fast forward to Brenemark, where osseointegration became a concept. And then obviously Shredded and all these guys in Switzerland that created the others. You remember at one point we went to meetings and there was a big dispute between the two groups, the Swiss group and the Swedish group. But then the US, let's create 3i. And they copied things. And then the copycat thing started. So now if you ask me, why do we have so many? And you made a good analogy. I don't even know what is the other thing that we have so many brands, chocolate, candies. I don't know, but I have to say it's money. It's great. It's finances because that works. It's a big market. It sells. So instead of, I'm just going to have my own, and they just tweak a little bit here and there. And nowadays, most people care more about cost than about quality. It's like cars. You can buy a top-notch German car. You can just go and buy a very cheap Brazilian-made car. How do you know? But now I see the big companies incorporating or buying small companies. So even Straumann, they had one kind. Now they own one in Brazil, one in South Africa, one in another France. So I think it's just, and then the clinicians, they always want a little bit different. Oh, I don't like that. So why we don't create? So someone comes up with an idea, they think they can build their own system. We all learn how to work with just one thing, and it's maybe two. So when something new comes up, you go, hey, why do we need 7 kinds of implants in just one company? Yeah, just
because this could be a discussion on a consensus conference.
That's a great idea. We should have a consensus conference on why do we have so many brands? It's probably who's going to sponsor it. We have to find a multi-company, multi-association.
Pick the 5 biggest and maybe convince them to buy all the small companies. No, I don't know. No, as we say in Switzerland, competition makes the progression. If there's no competition, if there only would be 1 or 2 implant systems in the world, I think the development would be much slower. So basically,
I think at this point, if you think we had only 2 models, 2 kinds of tissue level and Brenemark, and then it became Ankylus, I guess, the guys in Germany with the internal connection, platform switch kind of design, which nobody believed in. Now everybody uses that. So then it was 1,000 kinds. And now they're, okay, for that application, we need this. For this application, we need that. So maybe having 3 different designs would fit anywhere. And then, of course, we have the odd ones like ultra short or zygomas. Those not everyday kind of application, but for 80% of patients, maybe just 3 designs with different lengths and maybe even diameters you don't even need. Some companies have from 2 point something all the way to 6.5. Why do you need all that? Then it's personal preference. So it's a great idea for a big consensus conference. How many kinds of implants do we need?
Because your statement is right, because after all these years, there's also evidence, let's say,
Yeah.
on what works. But the problem with the evidence is that evidence, we're talking about scientific evidence, research. If you look at this, you don't have 1,500 implants. There's
Yeah,
not
no.
less brands that also have the budget, because
Yeah.
let's say 1,400 implant companies, they don't have
The money to put it
invest
on.
to
And
put it into research. So they are just
that is why they
copying.
cost less.
Yeah.
That is why they cost less. If you remember back in the past, one specific company would not launch anything until they had 5-year follow-up. But the other one will launch the moment they created. And they were getting the edge on the market until those implants started to fail. But now that company that used to wait 5 years, now it cannot afford to wait 5 years. They have to launch something in 1 year's time because it's based on previous research. So a lot of these 1,000, whatever number of implants, 1,000 is based on the other 200.
It's like
You can count.
like the story with the bone substitutes, like Geistlich Pharma did a lot of research
Yeah.
in the past. And then all the companies started copying the BioOst and the BioGuide and all these. Now you have membranes and bone substitutes from many companies, but honestly, they did not do the same research on their product. They're just saying, yeah, this is as good as. They have proven that this works, and now we have a copycat, or we have a better version. So what are your thoughts about this being a person at the university? Would you trust a material?
So we try to stay with the evidence-based materials. And as the European Union, South America, North America, there are different regulations for bone grafts. Like I know in Europe, they don't use a lot of allografts, human cadaver bone. In the US, it's the number one use, to the point that Geistlich, which made its business on a xenograft, incorporated an allograft material in the US because they were losing market because the US surgeons were not that used to a xenograft. So we try to we are a teaching institution. We're not a for-profit. We have to make some profit because part of the dental school's money comes from treating patients, of course. So we cannot afford to lose money. We have to make some money, but we have to teach the students. So we have a third component, which is we're dealing with the less experienced hands. So in less experienced hands, I want to use the best material, well documented, that I have also experience on. Because there's that factor. And every time we do something and it fails, I have to own that patient and do it again. So we have to teach the residents and students how that works. So we tend to work, at the same time, we cannot stay with just one brand because we have to teach them what is out. So like we teach them Straumann implants, they go out, they will do another brand. So we teach them the concepts. And hey, if you use this brand, this is the design. Now, look at whatever brand you will use, they will have something very similar. So just you understand the concepts, primary stability, surface connections, selection of abutments, all the restorative aspects, you'll be fine as long as you understand the fundamentals of it. For bone grafts, same thing. Still like autogenous. My experience is mainly with xenografts because I still use that a lot. And then now we have bone enhancers, which are PRF and PDGF, all those things that we use if evidence like PRP came and went away. Nobody uses that anymore. Now PRF is the thing it seems to be staying. So we use that for some indications. And then we have another company that provides us with a similar but slightly different because they have maybe a slightly different membrane, titanium reinforced, that kind of thing that we cannot have with just one company. So that is basically what I'm still, believe it or not, an old school brain with a modern mindset.
That sounds interesting.
I like to call myself a guy that is old enough to have done osteosynthesis with wires, but I fully understand a virtual surgical plan fully guided everything. So you have to teach them, this is here to stay. It's not going back. But if they know the fundamentals, basic principles, biology and anatomy, they will do fine. And
So you're more telling that you also have an interest in digital technologies.
yeah,
Over the last years, there have been some initiatives to do more virtual reality, augmented reality training dentistry. And I always tell people, look, this is if you wear an astronaut suit with the astronaut gloves and trying to perform a very precise task. The only thing that I see really works are this drilling things. This have the touch feedback, like the things that started at ACTA in the Netherlands, this preparation robots, where you have a hand
yeah,
piece and you can then prep teeth and feel the pressure and everything. And there's also some research that students who had the training with these machines, rather than just prepping on models, on typodonts, had better results over time. So basically, after dental school, it starts from zero, and then you get into in the real world, and you have to learn
right.
again and restart leveling up your skills. But what are your thoughts on virtual reality, augmented reality teaching in dental schools?
I think it's a really good tool to teach as long as you know what you are teaching. So here, for instance, every year we do a workshop on virtual reality with haptics, which is the like joysticks, and they put that big VR glass. So that shows the first year residents, those that don't know a lot, how before they go into surgery, what instruments they have to use, how the step by step of the orthodontic procedure works. So pick up the guide, put it on the model. They feel the vibration. They feel tapping. They have, okay, get a mallet, get a saw. How do you do it? It's like a video game, but they are interested in seeing the real thing. But that's at least it's something that is better than just watching on the lecture. For the dental students, they do, I don't use it, but they do have a lab where they have like a handpiece and they prep crowns and they have the haptics feeling of it. I still remember one of the first high-tech things that I saw was in your office. I remember visiting you in one day and you said, okay, I have to see a patient. So you scan the patient, which nobody had an intraoral scanner, and you had one. That was 12, 15 years ago. I don't even remember. And you scan the patient and you say, a patient sits here now, waits a little bit, and let's go get a copy because I did my machine to print the crown. And you printed the crown and delivered that on the same day. So how can you do that? So I remember me and my prosthodontic colleague, we came back home and said, we need to buy those things. It's number one, really fast. Number two, and that was back in the day. Today, you can do it even faster.
No,
So
absolutely.
we were
Then,
always, yeah,
yeah.
we were always impressed with that. So here we do a lot of technological things on implants and in orthodontic surgery. For the surgery itself, my orthodontics, they are fully guided with what they call patient-specific plates. They're all CAD/CAM titanium printed. And implants, we do mostly static guide. We do have the navigation device, the dynamic guide that we use. It's a bit faster on the workflow because you don't have to print anything, but it takes a different mindset to look at the screen and not look at the patient. But for teaching, guided is really good because the residents tend to look just at the X-ray. They have no experience. You can look at a CBCT and not even, okay, this is where the implant needs to go. But if you've done only 2 or 3, they need to do the virtual planning on the software. And some we actually make it mandatory that is fully guided. So they know exactly where that goes. Some, you can freehand it with just a duplicated denture or something. It's because they have to just learn both ways. Because if it fails, how do you save it?
Yeah.
For the dental students, we actually have models where we teach them to do dental extraction. And we actually are publishing a paper now on the Journal of Dental Education because we noticed that the students that have never done a dental extraction, after they are models that go in the dental chair and they simulate luxator, forceps, put a suture, organized in the same position. When they went to see a patient, they felt more secure, more confident to do the extraction. It's not haptic, it's not high tech, but I do like that idea of practicing in something before you actually go touch a patient.
Absolutely. No, because this is what many dental schools are lacking these days. We see that also in Switzerland, that the dental students know more, but are less manual trained. So the manual
Yeah.
skills are a little bit. I remember when we were students, we had the majority of our work was really working,
Yeah.
doing the full
Yeah.
dentures, doing preparations, doing the
Yeah.
PFM crowns completely from zero to everything ourselves. So I felt to get ready for my professional career in a certain way. If
Yeah.
you look back, it's always, if you graduate, you think I'm the biggest, I'm the best. But then you realize that you still have to learn a lot. But compared to 30 years ago, the students these days are less prepared to the professional life, unfortunately.
Yeah.
So there's a lot of need of postgraduate training, and
Yeah.
that the young generation needs to accept that they need to train themselves before really becoming good dentists.
Right. I agree, which brings a big opportunity for CE courses, continuing education courses. But I do agree, especially here in the US, the big challenge for me or change in that was that in Brazil, we had a lot of hands-on components, seeing more patients, a lot more of the, even like DECO courses were dedicated to technical details, seeing more patients and the developing skills. Whereas here, the main focus is on the medical management of the patient. You know, a third year dental student knows more about medicine than my first year oral surgery resident in Brazil. But I can get any third year dental student in Brazil and they can show my second year resident how to do an extraction, put an implant in, or do a pap crown much better than anybody because they are just more focused on the technical skills. But it's hard to find a balance between good didactic knowledge on the medical area. And here we unfortunately have a lot of sick people. People are aging, there's medication, there's diabetes, there's this, there's that. And they have to manage the medication portion, but also develop skills to deliver really good dentistry. Dentistry is a highly specialized skill. If you don't have good hands, you're in
Absolutely.
trouble.
Absolutely. Absolutely.
Yeah.
And this makes maybe also our profession still be there, although we have a lot of artificial intelligence,
Yeah.
that maybe our handwork will not be replaced that soon by a robot.
Yeah.
Maybe to finish this discussion, that's an interesting last question to ask you. Do you think that we will be replaced by robots?
No, no, never. Because number one, our dental profession is a relationship thing. You have to develop really good social skills as well. And I always say the same. You see really good, skilled dentists, students that are talented with the hands, artists, but they are so shy and they cannot develop really good social and communication skills, and they bomb in private practice. On the other hand, you see these guys are all talkative and nice and everybody likes them, but they have bad hands. They are always full of patients, doing not so good treatment, but they have always patients. So I don't see our, or even the medical profession being replaced by machines or robots. I do see some procedures in some parts can be helped by artificial intelligence and robots. I was in a conference last weekend and they had this showcase in the new robot thing that, number one costs $120,000. Whoever has it, they love it. But it's maybe a marketing tool. But they say it speeds up the process. You touch on it, it looks good. But if I still have to hold that, why do I need a robot? So I don't know. It may, and I don't know if certain patients would like to be drilled by a robot handpiece. Now, if I'm doing highly precise brain cardiac stuff, then maybe parts of the procedure, if the technology is so great, but you read reports where the light goes off. The machine just, an electric self-driving car, and sometimes it doesn't turn what I want it to turn. So I have to take over. And this is high. It works great. It works great. But when it stops, it stops. So it's not ready for prime time, we say here. It's,
Yeah, that's I love this as a final statement for the discussion of today, because that's the same way I see that whole medical profession. There was an interesting interview with the young medical students in Austria who's also doing research in artificial intelligence. And he also was saying we can enhance the quality of our work with using AI, but we cannot
Right.
replace, because patients, they want to see in the eye of. So what you were saying, communication is still something important than patient wants. Yeah.
Some parts of the work we do can be helped by AI, either like interpreting a radiograph or segmenting. I get a CBCT, pop it into the AI. In 3 minutes, it comes back perfectly clean, segmented, nice. I can do a virtual extraction. I can assess my patient better, but still, that's my brain controlling the thing. But some steps can be expedited, streamlined by AI. But I don't think will ever be replaced.
No, that's a perfect statement, Demar. Thank you very much for taking your time.
Thank you.
There's so many things we could talk about. And
Yes,
I'm sure that we will do another interview talking about, look, there's the whole topic of ceramic implants, or where are we heading? Just maybe a final remark. I had an interview with Diego Gabatuller, the CEO of Geistlich, and he was telling me Switzerland is the first country where implant numbers are going down.
Oh, is that right?
Basically because the Swiss population takes more care of their oral cavity.
That is a good thing, though.
Yeah, that's perfect. That's great. So basically, then the initiatives from the 16s of Professor Müllemann and Marthaler, all these guys on prevention, maybe finally are getting a little. But we see it also in our dental office that the younger generation has better teeth.
Yeah.
They take more care about, but it still depends on what country you are.
Here in the United States, this is another big difference, Alessandro, is that culturally, people do not want to keep the teeth, and the market is so bad. We're now writing papers to say, please do not extract healthy teeth to put implants in a dentary, and this all-on-4 kind of concept. It's just a nightmare. Yeah, I don't know how people sleep, but they just social media, just start looking at it, and the advertisement, they just, hey, there's a little bit of periodontal disease, instead of treating, saving the teeth, doing all that, all teeth out, cut bone out, put implants in, hide the transition, done, go home same day. It's a mutilation of patients. So the United States, for me, was also a big surprise, is behind in oral healthcare, behind many third world countries, like or even Brazil. It's better at that for the favorable population, the poor population. They have better access to oral health than here. And culturally, everybody wants to save the teeth, the dentist. Whereas here, it's a lot of really good teeth are being extracted, bone is being removed, then that fails, and then you have to deal with this severe atrophies. It's the number one problem right now in England, that if you practice or learn like I did in Switzerland, in Europe, and then in South America, come here, it's a completely different ballgame. So we have to be strong to not go into that and teach the residents and try to challenge the market, because this is why US is, I think, now the number one market worldwide.
Yeah.
But that's another hour discussion.
Absolutely. No, prevention is a big thing, and we will talk about that more in our next interview. But thanks again, Waldemar, for taking your time. And if you have any questions, not only to Waldemar, but in general to all the interviews you have done on Dental TV, feel free to drop us a message, and we will always answer your questions with a video that helps you to level up your skills and stay ahead. Thank you, Waldemar, for your time. And
thank you, Alessandro. Have a great day.
Brush your teeth. You have nice teeth. You have to take care of them.
That's right. And floss. Thank you. Have a great day.
Yeah, you too.